picking it. No.
Right, Frank. That's correct. Hello, everyone.
So how's everybody's weather at this point?
It's 50, I think, today. 49,
50?
I think, was the high today.
Right
Yeah.
on.
We probably got up mid-70s.
Oh, nice. That's warmer than here, I think. We're like in the
Very windy.
mid 60s or something.
Is my picture supposed to be up there too? You don't want me, do you?
I see you. Yeah.
Okay.
Yeah.
Shoot,
Oh, yeah.
was
We want you on.
getting ready to do something lewd, but no, never mind. No, I'm kidding. I'm kidding.
What's in that? What's in that coffee mug?
It's water. I'm trying to hydrate. I've talked for 6 hours straight today with 7 new patients.
Wow.
Oh, goodness.
I lost my voice about 3:30.
I was talking about your, I didn't say your name, but I was talking about your exposure, like your acrylic story. How it's like, with a doc, was it yesterday? We were having the whole conversation about like fumes and stuff, and I was like, "Oh yeah, I got a story for you."
Oh yeah,
it's not good.
Yeah.
All right, I feel like people are still joining. We'll give it just a couple more minutes before we get started. About 2 more.
So Terry, of course, you looking sharp as always, and Trish, like you're always looking amazing. I gotta take a tip from you guys. Next time, I'll work on it. I'll have a nice long hair like you, Trish. Next time we're on.
Okay, I want to see that. I want to see that.
I have seen Frank in a couple wigs before. That's been entertaining.
Oh yeah. It was Halloween, by the way. Nothing weird.
All right, I'm glad you
Okay, maybe it was
clarified that. You clarified that.
All right, everyone. Let's give it just 1 more minute.
Yeah, if I was home, there may be something different in this, but here at the office, it's just water.
How's the place going? Terry, how's
Well, the new house, you mean? They're getting ready to pour the foundation. It's taken forever to get all the permits, and we've had weather off and on, so that puts a halt to all the grading and dirt movement and everything. So we've rented a place downtown. We're going to do some urban living, you know.
Is your house sold then?
Yes.
Okay.
Yeah, actually, Chase bought the house.
Oh, he did. Oh,
stays in the family. That's cool.
Gonna come back to Oklahoma.
The family. I don't know if he's coming back to Tulsa or not, but he said this is the cheapest way to get in the real estate market. He can't do it out in California.
Sure.
California is rough. It is rough.
And he has a place to land if it is open.
So we've been moving, packing. I talked to Jean after I got finished working. She said, I've been packing all day to move into the apartment because we have to be out by June 21st.
Oh, you still got a little bit of time.
You don't know what all the crap we have though.
Yeah.
The bigger,
you couldn't rent it from Chase.
Yeah. The bigger the house, the more stuff you collect.
Fair. And the years you've been there.
Yeah, we've been there about 25 years now.
Yeah.
Oh yeah. Yep. It's funny. My sister was moving this weekend, and they've only been in that house 3 years, and she's like, I can't believe how much we accumulated in that amount of time. It's crazy.
Mm-hmm.
Yeah.
Yeah. When I moved here, I gained 2 people. So
yeah.
Oh, in the old house. It was so easy to move into the old house, but then we moved out of the old house. I'm like, we're gonna need movers. This is a little much.
We've been weeding out the stuff we didn't need, the extra clothes that didn't fit anymore, things like that. So we've gone through 1 and 2 sessions in that. And I said the last session, I'm bringing a dumpster in, and
Fair.
everything's going into the dumpster, that we don't take.
Yeah, fair. I know. Sometimes I feel like everyone just needs a little dumpster clean out every spring. You
Oh,
know?
absolutely. I did it at the office a few years ago, and it was amazing. But I look around now, and it's just as full as it was whenever we got rid of everything.
Fair.
The girls down here are pack rats. They save every
Wait,
box.
isn't that your daughter?
Well, one of them, yeah.
Yeah.
They save everything that comes in, boxes. Gee, what?
Models, appliances. So
Models.
You
they
never know
can
when you
put
might
them
need it.
back.
You never know when you might need it.
Telling you, we've run out of space, so we've gotten into the point where we're just giving the patients the impressions and say, "This is your responsibility. If you lose a appliance, just bring me your impressions, and we can get it done."
Mm-hmm. Fair. Yeah, that's fair. Alrighty, well, I think we're going to go ahead and get started here. Good evening, everyone. Thank you so much for joining us for our monthly webinar. We host these every single month that cover different topics related to sleep and TMJ, as well as practice growth in these areas. So if there's ever any specific topics you'd like us to cover, feel free to put them in the chat box or shoot me an email, and I'm happy to put that on our list for the agenda for the year. The best way to view the webinar today is going to be in speaker view. So if you actually click the upper right-hand corner, you can select speaker view, and that'll allow you to see Dr. Bennett and the PowerPoint side by side. I think this is kind of the easiest way to see what's going on. Your camera is off and you'll be muted for the duration of the webinar. So if you have any questions, feel free to raise your hand and I can unmute you, or also you can utilize the question and answer box. I'll be monitoring that as Dr. Bennett does his lecture to get those questions answered for you. So as you know, the discussion today is going to be on a comprehensive exam for sleep and TMD. So feel free to ask questions, like I said, throughout the webinar, and then you'll receive a promo code at the end. So make sure you stick around for that. I'll pass things over to Frank now to talk a little bit about True Function for those new faces on here before we get started.
Wonderful. Thank you, Trish. Dr. Bennett, first off, we want to thank you for joining us and sharing your time with everyone and your valuable knowledge. So we appreciate you for being a part of this. And everyone else, thank you very much for joining us as well. We know that you're all busy and it's probably at the end of pretty much all of your days. So thanks for hanging out with us. And we definitely appreciate you joining us and learning a little bit and getting to learn from Dr. Bennett. A little bit about True Function. We started about 25 years ago, so this is our 25th year, quarter century. That's pretty amazing. We're still alive and kicking. But really, we have an amazing team, and we just keep building on it. And so I'm very proud of everyone that we work with. Trish is one of the amazing people that I get to work with every day, so I'm blessed. Again, True Function is relatively unique. All we do are oral devices, either sleep apnea or TMJ, some occlusal guards, and that's it. We've gone from orthodontics in the beginning to TMJ to evolving to full service a few years later. And then, about, I don't know now, close to 15 years ago, we decided, you know what are we great at? What's our passion? And that's what we're going to focus on. And this is what we do. So we only deal with oral devices. We do have a very, wide understanding of dentistry as a whole, but really, this is what we do. Appliances, TMJ, oral devices for sleep. And of course, more and more we're doing providing digital services. So we look forward to working with you and understanding more about your practices, and also helping to support you in your continued growth. So thank you for being a part of this, and I'll hand it off to Dr. Bennett and Trish.
Excellent, excellent. So a quick little personal share about Dr. Bennett before we get started. I love this story. I love this story. So my mom's also in this industry. And the fun thing is, I remember when I was little, her talking about this clinician in Oklahoma that was such a wealth of knowledge on all things TMD. And I remember her going to his office for an in-office training. And she was so excited when she got back and was sharing all the valuable things that she learned. And she couldn't wait to get started implementing them into her practice. And so now, fast forward 20 years, now I get the pleasure to work with Dr. Bennett regularly and travel with him around the country to watch him share his knowledge with new clinicians. And so I can confirm that the exams that he's going to show you today are tried and true. And it's such a pleasure to spend time with you. A little bit more about him specifically is in 1977, Dr. Bennett graduated from the University of Louisville School of Dentistry with his doctorate in dental medicine. Dr. Bennett has more than 40 years experience in the private dental practice, but for the last 32 years, he's shifted focus. So for over 3 decades, Dr. Bennett has limited his practice to conservative treatment of temporomandibular joint dysfunction and sleep apnea. This has allowed him to expand his area of expertise in dentistry and to continue to treat his patients with the utmost ability. To continue to expand his knowledge in craniofacial pain and dental sleep medicine, Dr. Bennett is a member of many organizations. He also holds diplomat certifications in several of these organizations. In particular, Dr. Bennett has been extremely active in the American Academy of Craniofacial Pain. Having served on the board of directors for more than a decade, he's also served as a program chair for 4 years, as the president of the AACP for 2 years. Additionally, Dr. Bennett served as the AACP Institute Director of Education, which allowed him to organize and provide education around the treatment of TMD and dental sleep medicine. Among many certifications he has attained, some of the diplomats are the American Board of Craniofacial Pain, the American Board of Craniofacial Dental Sleep Medicine, the American Board of Dental Medicine, the Academy of Pain Management. So currently, Dr. Bennett divides his time between TMD and sleep apnea, practicing in Tulsa and lecturing for dental schools and several organizations across the country and internationally. Dr. Bennett and Dr. Mayur Patel have also started the BenPat Institute for Education and provides TMD and sleep apnea courses for those 2 disciplines. He also enjoys being with his grandkids and playing golf and enjoying the sun and the sand in his beach house in Alabama. All right, well, thank you for joining us this evening. So I'll pass it over to you.
Gosh, Trish, every time you say that, it makes me feel old, you know?
You're not old.
Saw your mom years ago, and now I'm traveling with you. Love it. Love it. Oh, it's a pleasure to be here tonight and to do this for you, for the participants. This has been a passion of mine for the last 33 years, and it still is. And I tell people my practice is not a job. It's more like a hobby, because I get to come to work every day, meet lots of new people, and help them with their health, which is it's very rewarding when you take these people and make them feel better. So we get started. Frank said I had about 2 hours tonight, I think, or Trish did, something like that. So buckle down and we'll try to get finished in about 50 minutes, I think, instead. So first thing is, proper diagnosis is the key to proper treatment in anything we do in dentistry or anything like that. I know that there's probably a lot of you out there on this webinar that aren't treating TMJ, and that's okay. You don't have to treat the TMJ aspect of this. Some of you may treat TMJ and you don't treat sleep. Some of you may treat sleep and you don't treat TMJ. That is my practice. So that is my routine that we do every day on every new patient who walks in the door for us. And I've just found it to be, when it's this compact and we know exactly what to do with every patient, we don't vary. So things go very smoothly in the office this way. And for crying out loud, I was hibernating. Don't you guys ever take a pulse? Sometimes we just jump in and start doing things. You know, there's courses out there that tell you, you know, you can make a sleep appliance. All you need to do is look how far they can move their jaw forward, take 80% of that or 70%, and take a bite registration there, and things are going to be hunky-dory. Not always. So some of the things I'm going to show you are things to look at for your patients. They're also going to help you look out for, especially sleep, these sleep patients out there. in your practice that you may not be seeing, you may not be mining to treat. Oops, sorry about that. Here's a paper by Paulo Canali back in the 2000 sometimes. At the bottom, it says that what they did was evaluated the patients for the prevalence of pain. These patients came to the clinic for a sleep study to be done. And then they went ahead and evaluated for the presence of pain. And I've got all these things at the bottom here, so I can't see that for sure, but it says like 75% of the patients presented chronic pain related to TMD, categorized as low disability pain. And then I've got blocked out because of the screen, and the high prevalence of TMD on the current study indicates that patients with OSAS referred for oral appliance therapy required specific evaluation related to TMD. So basically what the study came down to, it was that there is a relationship. If you're treating sleep, there's a relationship of TMD patients in your sleep population of 65 to 80%. And if you're treating TMD, it's vice versa. So you can't hardly separate out the two different disciplines in here. And that's the reason we just made everything easy. I'm kind of that simple person, so we did everything the same way in our office. So what we look at, there's different things we look at. First, we do a structural and postural evaluation. I'm looking for different things as I'm looking for these pictures on these patients. We do muscle palpation. So I'm going to take you back and do a little bit of anatomy for you, because I found out in lecturing, people get out of school and they forget their anatomy and stuff a little bit. And it's very important to do palpations on these patients for sleep patients, especially because you're not looking for pain on these patients, and they may not be telling you that they have any kind of tenderness or pain. And if you don't find this on them in your evaluation, they may come back to you later on and say, your appliance has caused my jaw to hurt. It's caused my cheek muscle to hurt. It's caused my neck to hurt. But if you knew these things ahead of time, you've got answer for them. And then we do an TMD evaluation. I found also that a lot of people don't really know what that clicking popping is. So we'll go through that pretty quickly in here. Do an intraoral evaluation, which you should be doing on every patient, and that you see, a dental occlusal evaluation, and then I'll show you the radiographs that we look at on all of our patients. So the photographs that we take will show the head posture. I'm wanting to see if they have a head tilt. I'm wanting to see if they have an occlusal cant. We look at shoulder posture, lateral pelvic tilt, and leg and feet evaluation. So what I'm trying to do is do a whole body structural evaluation, whether they have problems that they're having to accommodate for, which can change everything. When I look at the occlusal films or the pictures head on, I'm looking for smile lines. I'm looking for eyebrows. I'm looking for a head that's tilted or whatever. I'll show you as we go through. Now, this would be nice if everybody came in and clothes like this, because you can see the body lines, but that's not what they come in. They come in shorts. They come in dresses and slacks and different things, blouses that, cover their shoulders. And so you can't tell as much. So we have a sectorgraph that we have in the very back there, and we can kind of tell off of that. But on this, where you're looking at the front, you're looking for the arm length, how they hold their arms when they stand. If their arms are forward like this in the very left picture, they've got good posture. And in the center picture and in the other picture also, if their hands come forward so that their knuckles face forward, they've got some forward head posture going on, which is going to affect the shoulders and the neck. And so we look at this, we look for the shoulder tilts in there, we look for pelvic tilts, and also how the feet stand. Now, this is one of my staff members, and we did this just the other day. And if you can see and look at her, oops, sorry, that's foam. If you can look at her, you can see that her left shoulder, or the right shoulder as you're looking at, is a little bit taller than the left shoulder is. Or I'm sorry, her right shoulder. If you look at her head, she's got a tilt to her head also. And look, if you look for her smile line, she's got an occlusal cant in there. So an occlusal cant, a lot of times, that's one side higher than the other, could be, okay, that's the way the orthodontist put them together, it's the way nature put them together. But it also could also give you an indication that possibly they've got some osteoarthritic degeneration of the side that's the shortest in there. So it's just a little thing I look at right off the bat to just kind of give me an idea of what's going on. And you can see her eyes, one eye's wide open, the other's kind of squinty. So she's got some abnormalities going on here, and this could be just growth and development for her. And then when we put the stick in there, look at the occlusal cant on this. She's up to her right side, which is opposite of the way her shoulders are. So she's accommodating for how she's put together. She may have had a leg injury, a knee injury, or a growth defect in there that's helped cause some of this accommodation. So those are the things we want to look at. Okay, anatomy review. If you have any questions, like Trish said, please just put them in this chat room, and then she'll break in and ask me, because I don't mind questions at all if you have any. So these are the muscles, the main muscles we look at. Now, there's a lot more as we do our real comprehensive TMD, a few more anyway. The temporalis, we look at the anterior, middle, and posterior areas of the temporalis, palpate those. The masseter, or several areas, will palpate. The SCM, sternocleidomastoid, will palpate the sternal part of that. We'll palpate the clavicular part. Trapezius would go across the back and where it attaches at the base of the head. I found out that the neck is a big player for headaches for these people, whether it could be TMD or sleep. If all these trapezius, SCM, clenchers and grinders, because you're going to have those in your sleep practice, just like you do in your TMD practice, they're going to be sore in a lot of these areas. The digastrics, the pterygoids in there. And then we're going to evaluate the intra-articular region with our little fingers by putting the finger in the ear. We're going to do a preauricular region also, which is in front of the jaw, front of the ear up here, right at the back of the jaw, and have them open and then palpate that area. And then we'll palpate the occipital area at the back of their head. So the temporalis muscle comes off the infratemporal fossa, comes into the parietal bone up here. That's where it originates, come down to a tendinous attachment in the cornoid process. This goes all the way down. If we see a high cornoid process on our x-ray, higher than the TM joint or the condylar process, these people have got condylar hyperplasia. It means they're a big clencher grinder because they get additional cartilage added to this bone down here, which then makes the cornoid process appear longer. Because the muscles of this, the pull of this muscle, you can see the anterior parts pull straight up, the middle part pulls back, and then the back part pulls almost straight back. So we'll palpate these muscles, and the reason they're important is on the left or the right side of your screen there, you'll see trigger areas. I'm looking for trigger points on these too, because these people, their pain, I never look at where they're having the pain as necessarily where the pain comes from. I'm always looking for other regions that could be, that if I touch these regions and palpate them, it can produce that pain going across the eye, like in the very top left picture, or going down into the teeth. I've seen lots of people have a temporal problem, temporalis problem, like number C down there, and have toothaches. I've seen lots of people through the years get 2 to 3 teeth extracted after they'd had root canals and crowns because the pain was still there, and they became dental cripples. So I loved looking at for the relationships in the muscle palpations. So if you look at the temporalis all total, that's the area of the head that the temporalis can cover with just tender areas, the palpations, the trigger points in there. So we'll hit 3 points in there at least, see if it produces pain anyplace else or is really tender. We'll make a note of that on their charts as we go through. This is a book that I have that I was introduced to probably 25, 30 years ago now. And I think they put it all in one book. This was upper half, and when I bought it, the lower half too. And it's great for trigger point myofascial pain and dysfunction in there for those who don't have this. Here's a chart that you can get. Also, it has those same muscles we talked about on here, and you can see all the areas where they can refer on the head. So let's take, for instance, lower left down there. If you look at the SCM, it's got triggers all the way up in both the sternal and the clavicular part, but that can cause headaches, migraine type headaches around the eyes. And the SCM is the only muscle that crosses the midline like this too. So again, when people come in with migraine headaches, I had 3 new patients today. They all had complained of migraines. All 3 of them have been to the neurologist, migraine medication, and none of them worked. So that tells me it's basically not a migraine headache they have potentially. So then I start looking for base of the head, other areas to see if I can produce any kind of a pain back there for these people. This is a very important chart for TMD people. So if you don't have it, you need to get one, something like this. The masseter muscle comes off the inferior or the inside of the zygoma, attaches down on the angle of the mandible and up through the back part of it. Second strongest muscle in the body, this and the temporalis together can produce up to 200 to 300 pounds per square inch at night for people when they clench. So this is a reason, or even more, this is the reason people can break their teeth or grind their teeth down flat. They've got a tremendous, tremendous power in there working on these teeth. So if an airway is not good enough for these people to get good air at nighttime, if they're compromised in here, maybe snoring and stuff, if their airway collapses, they sleep on their back some, they're going to start moving their jaw forward to open their airway, okay? This is a prime area for people to have TMJ pain. In fact, when people come in, I make them show me, where is your pain? And some of them will show this area, and I'm going, that's not your TMJ, that's your muscle in there. And then here's the parts in there. I'm going to have to run through pretty quick here. And then when you put the masseter parts together, that's what this looks like. SCM's another big one, comes off the mastoid down the clavicle and also the sternum. Here we go. It's a main head positioner. So this is the one that's injured in accidents and things. You just walk your fingers up the different areas in the 2 parts of the muscle and look at all the places in here it can cause pain. So big place for headaches and ear issues for people. Trapezius muscle goes from the acromion to the base of the head all the way down to T12. We get a lot of trigger points in this area right at the base of the head and in the shoulders across like that. And that can cause these types of pain for people also. So again, here's our headaches, migraine headaches. Greater occipital will cause the migraine headaches. The lesser occipital, a lot of times, area will cause the crown of thorns or the headaches from the back of the head to the eyes. And here's more triggers for these. And the digastrics, those tighten up too for people, especially if they've got TMJ problems. And these are the trigger points for the digastrics. We don't see that as much. We do see the pterygoids. Now the pterygoids come off the pterygoid plate, the lateral portion of the pterygoid plate. And if you look at the top arrow, that comes in and actually attaches to the TMJ capsule in there and becomes the capsule. The inferior pterygoid attaches to the condylar fovea in there. It's what helps, excuse me, both of these muscles are what helps pull the jaw forward in their rotation and translation movement. The jaw does actually come out of socket, but that's not the problem most people have. The problem most people have is the disc gets dislocated, not the joint, not the condyle, but it's the disc that gets dislocated. And then the pterygoids can give you pain in the TM joint, can give you pain back in the ear, and also cheek pain. So knowing these are, I got to get rid of that somehow. I got some.
Dr. Bennett,
Uh-huh.
can tension in the SCM cause tendonitis?
Yes. Yes. That's one of the main ways that you can get tinnitus is the SCM. But there's a lot of ways you can get tinnitus. But when stress and things, since COVID, these are statistics I saw quite a while ago that 21% of the people who had COVID, they started having tinnitus, and 21% of the people who had vaccinations started tinnitus was something that they started complaining about. So yeah, it's important to palpate the SCMs. And if you palpate it and squeeze it, you can make the tinnitus better or worse. So that's a kind of an idea of knowing which one, where the tinnitus may be coming from. Trish, there's something that, there it goes away. Thank you. So the medial, let's see, what was on? Medial pterygoid comes from the inside, the medial aspect of the pterygoid plate, and comes down and attaches on the inside of the mandible, just like the masseter does, forms a sling down there. So you got to go into the mouth and palpate that. And one of the couple of places you're going to get some TM joint pain with this, ear pain, and then facial pain again with the palpations. Then this area I call the Devil's Triangle because you've got all these muscles, the rectus capitis, the major and the minor, the oblique capitis, the oblique inferior and superior semispinalis capitis, the longissimus capitis. These all attach at the base of the head. So if you've got neck issues, you've got that person who sits at a computer all day long, or a dentist who has his head down all day long with bad posture at the dental chair, these muscles can tighten up around the nerves that come out, the greater and lesser occipital, and cause a nerve conduction problem to the top of the head and cause headaches for them. So this area is a big area for me to look at and also to do injections in to help these headaches. And here's the semispinalis. This is what we call the crown of thorns because it's just like somebody pushed a crown down over your head. And then a capitis can go to the top of the head. Don't think your patient's crazy. I know when I started doing TMD, I was told in school, don't treat TMD patients because they're all crazy females. You'll never get them well. They need to be on antidepressants, pain medications, and muscle relaxants. Well, lo and behold, in most cases, I do meet some crazy ones every now and then. We keep 5 at any time in our TMD practice. We get rid of one, and I'll be darned, here comes the next one. But I had a lady come in and said, I can't brush the top of my head. This was way years ago. And I looked at her, I'm going, okay, this is one of those crazy women, you know. And we put the orthotics in for her, and her muscle tenderness went away up there. I didn't know what I did for her until I got exposed to the pressure points and things in here, referral points. And then when you put the pain patterns together of the SCMs and the trapezius, look how much of the head that covers. So see, it's what I said. Don't just think because you have a headache around the eye, you've got a migraine, or up here, it's all tension headaches, you know, where the X's are. it can be caused by something else. So a good palpation technique in here is valuable for you in both your sleep and your TMD. Sleep, because you're putting down everything that they tell you. So if they come in with those same complaints down the road, they can't tell you, they can't blame you for causing these things. And people will do that, a tooth movement or anything like that. So the next thing is we look at TMD sounds. They can be determined by Doppler, which is just an amplified stethoscope, joint vibration analysis, which is a machine that you can buy that you have little headphones that go on and they'll over the joints and it'll give you a readout on those. Clinical exam is what I use. I have two very special instruments in my office. They're called my fingers right here. So I use these and just place them on the joint like this, have people open and close. If I can palpate any noise, that's significant for that patient. That's a TMD problem. If you can't do it here, you don't hear anything, you can put your little fingers in the ear and have them open and close. And this will pick up those subtle sounds in there. Sonography is another electrical device. Of course, you can use the stethoscope or via the external auditory meatus. And there's a picture of using a stethoscope in the bottom and then fingers on the top part in here. I'm listening for any noise, whether it be a click, a pop, a crunch, a grinding noise in there. The grinding, the crepitous noise you hear them described as all sand in the joints or wax paper being wadded up or glass. So those are all things that are telling you they've got a TMJ problem. So normal disc position and anatomy. I was at a dental meeting here in Tulsa, and one of the questions I always ask dentists whenever I lecture to them, and so I asked this question: from a resting point with your teeth closed, when you open your mouth and you hear a clicking, popping noise, what is happening? Are you popping off the disc, or are you popping on the disc? I had the pleasure of talking to some senior students at OU, Oklahoma University Dental School here in Tulsa, a couple of weeks ago, and everybody got this wrong. In fact, the faculty advisor that refers to me got it wrong also. I'm going to show you a film.
This is a normal temporomandibular joint. The disc is biconcave and it's located in a superior position.
Can you see the very top there? How
the central thin part of the disc is consistently lying in between the condyle and tubercle.
So there's three parts to this. The very top part is where the arrow is called the posterior foot. The area further down is the middle. And the very front, as it comes out to the right of the screen, is called the anterior foot. The area behind the posterior foot up there is the retrodiscal area. That area is full of blood vessels and nerves, okay? The disc is anywhere from 3 to 4 millimeters thick, should be. So when I take my tomograms, I'll show you what they are in a few minutes. I'm looking for spacing around the head of the condyle. And if I see that condyle further back, I'm thinking headaches and potential ear problems for these people. And here's another picture. The arrow shows the posterior foot. Then as you go to the right, you see that darker area in front, which is the middle, and then where it attaches to the ligament of the superior part of the lateral pterygoid becomes a little more tendinous in there. And one last picture of this. So if you look at ratios, we should have at least a ratio of 1 in front, 3 on the top, and 2 to 3 in the back as the perfect spacing for the disc to be in. I was taught in dental school, we took that jaw and wiggled it and pushed it back, and that's what's still being taught in a lot of schools. So we would jam that joint back as far as we could. We had to stop because it would only go back so far. And that's where we made our dentures and partials. But in 1985, that definition of centric relation changed. It's now down and forward, just like this shows us in here. So I see orthodontics that gets placed in this position. It seems like more of my patients now are having orthodontics or have had orthodontics, and they're in that upwards and backwards position, and they have TMJ problems. Trauma can cause this, growth and development, mid-face deficiencies a lot of times. Upper jaw doesn't grow out as far as it could, lower jaw gets trapped and keeps the jaw backwards in there. This is one with anterior disc displacement. Watch the pop now.
In this joint, the disc
it
is
pop on?
anteriorly displaced,
And now pops off.
and it's reduced on opening with a click. These joints demonstrate reciprocal clicking, which implies clicking during opening, followed by clicking during closing.
Okay, the reason you want to know this is because some of your TMJ patients, or I'm sorry, some of your sleep patients, if you don't treat TMJ, are going to have this problem. You put the orthotic in, the sleep orthotic, you bring their jaw forward. They start clicking and popping. They come into you, Doc, my jaw's popping. What did you do to me? And your answer would be, I don't know. No, the answer is, well, your disc was out of position to begin with, and we recaptured it whenever we put you in this forward position. I make sure every patient understands that when I put a sleep appliance in, because you very possibly can change their occlusion once you put that disc back in the position where it needs to be. They're going to have an open bite in the back. Their back teeth aren't going to meet. They're going to come to you because their dentist looked at them and said, I don't know what he did to you, but he screwed up your bite. No, we put everything back the way it should be. The bite was screwed up when they came in. So you need to know these things and look out for them. Their teeth have changed at this point in time too, because they don't have that 3 millimeter shim in there, but their teeth are together and they've got a millimeter space. So they've either ground their teeth down, they've intruded some teeth, posterior teeth in there, decreasing the spacing they have. Okay. Any noise, again, any noise you hear is a dysfunction for these people. And please, 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 I hope after this, you never tell anybody, oh, that's just a little clicking, popping joint. Don't worry about it, because there is a progression in about 35 to 40% of the people that they get to the more advanced stages. Year after year after year, it keeps getting worse and worse and worse. And I see those people that have been popping for 20 years. Somebody told them not to worry about it. Now they come in and maybe they're locked or other problems. So it is a problem. Just warn them they got a clicking joint. We may recapture the disc. If we do, don't worry about it. We can get it out of the way by just having you close real hard on your teeth. Okay. Because this will bother some people that they can't get their teeth together to eat. It bothers the dentist more than it bothers the people. See, I don't think like a dentist anymore, unfortunately, for you guys. I want to put the jaw where it belongs, because my TMD patients come in pain. And when I put that jaw in that 1:3:2 ratio or Gelb 4:7 ratio, that's going to take most of the discomfort and the symptoms these people have away. Their occlusion is going to be all screwed up. And I tell them that right off the bat. I'm going to mess your occlusion up while we're treating you. But you're going to hopefully get as close to pain-free as we possibly can for you. So most of the people, when they understand that, they don't have a problem. But if it happens to you, you at least now know, okay, we recaptured the disc. That's the reason the back teeth don't come together. And here's pictures of it. You can see the arrow up there. The disc is out of position. Look at the little amount of spacing on top now. Condyle's gone up and backwards, which is what happens a lot of times. They're going to pop over that disc whenever they open. Here's another one. See how the disc can get deformed too? So it's not that nice, smooth little biconcave disc in there. No, these things get all bunched up. This is what makes it hard for unlocking people sometimes, because we think all we need is 2 millimeters and they should be able to function over there. I'll guarantee you that disc is 5 or 6 millimeters thick, or maybe even thicker. And then here's another one. Okay. And one last one, I think. The thing's morphed in, looks like an amoeba or something like that now. Okay, now here's one without reduction. That means they cannot recapture the disc.
The next joint demonstrates anterior disc displacement without reduction, which implies that the disc is consistently lying anterior to the condyle.
They are closed locked. They can't open more than 40 millimeters.
During all mandibular movements, the disc is lying anterior to the condyle and at maximum opening.
That, I'm sorry, that retrodiscal tissue will only stretch out too far. And it seems like around 40 millimeters is that magic number. Again, disc is dislocated when the teeth are inclusion and never return. The disc never returns to the normal anatomical position. These are the people who come in and can't open their mouth. And you say, Mrs. Jones, can you open your mouth just a little wider for me? She tries and she can't do it. You look at her and you say, boy, you have a really small mouth. I may have to get a pedo handpiece out here for you. And she looks at you and goes, well, that's what every dentist has always told me. I see those people and I look at them, I say, ma'am, God didn't, or sir, God didn't give you a small mouth. He gave you a mouth that should be working. You've had a dysfunction for a lot of years. So this may not be painful for them, because this could go on for years and years. And the longer it goes, the more they're going to be able to open wider. Again, you need to know this. If you can't get their mouth open, you're not going to put in a 2-piece appliance maybe that's hooked together. You may want to do the 1-pieces, or the dorsals or something like that, so you can slip one piece in and then the other. Choice of what appliance you're going to use. This is a gal. She was getting her braces off, and you can look at the condyles in there. Now you know this is posterior in here. The day she went to get her braces off, she locked up in the chair. The dentist called me and says, hey, I've got somebody locked. You think you can help them? I said, send them over. We injected the joints for her, got her unlocked. And I said, the bad thing is he's getting ready to take your braces off. The bad thing is your position sucks. This is going to keep happening to you unless you go through about another 1.5 years of braces. This is a young girl. She kind of looked at me and go, okay. Dentist didn't want to touch her because he didn't know what to do for her. So I ended up finishing her braces for her. That's where she started. Look how far back the condyles are for her. Oops, sorry. Thought I had the before and after. These are what you're going to see in some older people. They're going to make noises. Sandpaper.
The next joint demonstrates a large perforation of the disc.
They're going to be bone on bone.
There is only a small piece of the disc remaining anterior to the condyle.
See how the condyle and fossa have modeled together?
This joint demonstrated crepitation and irregular movement.
Okay. So a lot of your older people are going to have that kind of a problem. So I mentioned there were 6 stages of internal derangement. Here they are. First, a clicking joint. Then they have to start moving their jaw maybe side to side to get it open. They start locking a little bit. Oh, I lock it in the mornings when I wake up. It only lasts a few seconds. I can get it unlocked. Then they may go into the acute close locking where they wake up in the morning, they're hurting because they've had an injury over the night from clenching or grinding. A chronic close lock is that person, the second picture movie back. Early degenerative arthritis or advanced degenerative arthritis was that last picture in there. So this is that progression I talked about. So again, there's no such thing as a little clicking joint for these people. Just let them know, if you don't know that much about TMJ, you've got a joint problem. You're lucky it's not bothering you at this point in time. It may at some time. You may want to get it looked at, or you can take your chances and see how long it's going to last for you. Okay, we do range of motion. For those who don't know anything about this, maximum incisal opening is around 48 to 52 millimeters. And that's from tip of tooth to tip of the tooth. Just use a ruler, that's all you have. Maximum protrusion is from as far back as you can go. So you have to kind of measure a negative number to as far forward as you can go. And that should be anywhere between 8 and 10 millimeters. Our left lateral excursions, you just have them sit there with I got a ruler. I just have them move their jaw as far as they can to the left and see how far they move, and then to the right and see how far they move. A deviation, this will give you some big hints on these people. A deviation is when a person opens, and instead of opening just straight like such, they've reached that next stage, they've passed that easy stage, they're stretching that retrodiscal tissue out just a little more, and they've got to go into their translation now to recapture the disc. Now, the translation aspect of the opening is almost a straightforward movement. So as I go forward, I don't have as much impetus to get over the disc like that because my jaw doesn't move like that in the translation. So they got to figure out how to get the wheels over the speed bump. So they'll move their jaw one way. If they go to the left and come back to center like this, it means they've got a dislocation on the left side. If they do this, where they go in a sigmoidal to both sides, it means both sides are dislocated, okay? Now, if the jaw, easiest diagnosis in the world, if you have the patients over, just look right at them, sit in the front of them, look at them, open wide. That tells me they've got a non-reducing disc on this left side. You've got one side that's opening, the other side that's stuck. So it gives you this. Right side may be the side that hurts, the side that's working okay, and it may start popping for them, but it's the other side that's really the problem for them. And then here's just doing the measurements in there. Again, he's checking for joint noises. First, upper right interincisal open. He's gone to the right on the left pitcher and gone to the left on the left pitcher or the right pitcher. Of course, you look at the periodontal health, caries evaluation, facets and abfractions should give you a little idea of what's going on. If you see facets, they're grinding the heck out of their teeth or clenching, okay, clenching their teeth. If you see abfractions, which we used to call NCCL, non-carious cervical lesions, I never heard of abfractions till I started doing TMD. We came out of school, we had never heard this term 50 years ago. 47 years ago, not 50, I'm sorry. And, you know, I can't tell you how many class 5 fillings in these abfractions, and people would just pop these things out by the time they came back 6 months later. And what they're doing, they're grinding these teeth and they're torquing the teeth right at the CE junction. And that's what's causing that wear erosion right at the CE junction. We call it toothbrush abrasion a long time ago. You look at the missing teeth, because this has something to do with especially your sleep devices, what a device you can use. You have to have so many teeth for certain of the devices. Mobile teeth, you don't want to put them on mobile teeth in there. Sensitivity, teeth and crossbite, fractured or injured teeth, that's just your examination that gets done. Then I look at the classes too. Class 1 doesn't mean anything to me though, because I see people with normal class 1 bites orthodontically that have screwed up joints. So I just don't pay any attention to this. But airway evaluation, we do look at the tongue level, tonsils and adenoids. And because I have a CT scan, I can get a good look at the tonsils and adenoids on my CT scan. Look at the soft palate and the uvulas. Is that soft palate, does it intrude on the airway back there? Is the uvula red and edematous? And if that's true, they're a big snorer, and that uvula just goes back and forth like this all night long. It's somebody like punching a boxing thingy, you know, just keep hitting it all night long and it gets red. See if they have a gag reflex in there. Nasal, we look at the nasal passages, the turbinates in the nose. Yeah, I do all this stuff. Neck circumference is important because if you get somebody with a 17-inch neck, they're more a male, they're more likely to have sleep apnea. If they have 16, female, 16 or more, they're more likely to have sleep apnea. But I can get a good idea from looking at the cross sections of the x-rays that I'll show you in just a second. But that's where we're looking at. So I'm looking at the uvula and soft palate in there. I'm looking at the palate-pharyngeal arch in the back there. I just had 2 patients today who had real tiny x-ray airways because that really draped down and took up some of their space in there. I'm looking at tonsils. Can't tell you how many adults I tell them they need to have their tonsils out. The dorsum of the tongue and a palatoglossal arch in there. I'll show you in just a second what all I'm looking for. Now, tonsil classification. I'm trying to get finished here. I'm going to be close. Tonsil classification is I'm looking in the back there and 0, do I see anything comes out of the tonsillar pillars back there? Okay. Number 1, you don't, or number 2, you don't. So that's a 0. Number 1, they're peeking out just a little bit. Number 2, they're coming out a little bit more. 3, they're beyond the pillars out there now. And 4, get those suckers out as quick as you can because that's closing off the airway for them back there. 3s are too. And I'll look at these patients and then say, unless you get this taken care of, I can put in the best sleep device for you. I could do everything I can do, and you're still not going to get success with your apnea the way we want it because those things are obstructing the airway. There's what some big ones look like. Look at the redness back in that area too. Look at that hypertrophied uvula, how red it is. And there's some, my lecture partner, Mayor Patel, calls those meatballs sitting there in the back of the throat. There's no way these people can breathe that much. In kids, this is going to be that adenoid looking kid with maybe diagnosed with ADHD or ADD because they're not getting good sleep. They get restless at school, so they're hyperactive. They're not breathing through their nose the way we want them to. They're not releasing growth hormone the way we want to. They're not releasing nitric oxide. These are the kind of the runts of the school class a lot of times. Have them just open their mouth and look back in there. If you see a high tongue level, that's kind of a problem for us, okay? That tongue kind of raises up and falls backwards and closes off the airway for us. So we're going to be less apt to have real good success on the one on the far right. The one on the far left would be good. In the middle, we can have some mediocre success with them. Don't let it keep you from trying if you see somebody like that, because if they're not wearing the CPAP, they don't have a lot of other choice other than you or spend a lot of money and get the Inspire.
We have a question, Dr. Bennett.
Uh-huh.
Is there any value in injecting local anesthetic into tender trigger points as a diagnostic tool for pain relief or for pain relief?
Yes, absolutely. So if I find a trigger point and I see that it's triggering, causing a headache or something like that, I had a temporal trigger point on this lady. She had had it for 5.5 years. She had had a root canal on a lateral incisor. The root canal didn't work. They went in and did an apicoectomy. She still had pain. So we as dentists, the next thing we do is crown the tooth. She crowned the tooth. That didn't take care of the pain, which I knew it wouldn't. That's just she was telling me this. And because she still had the pain, she finally had them take the tooth out. So now she's got a gap in there where it was number 10, I think. So a year later or so, somebody wanted to put an implant in. She's smart enough to go, okay, time out. She said, I need to find out what this is. Well, they sent her to me. She comes in and I said, what kind of TM joint problems are you having? She said, well, I don't have any joint TMJ problems. I've just got this pain right up here where my tooth used to be. And I know from those charts, I knew exactly what trigger point went to that. It's the anterior temporal trigger point right here. So I kind of pushed around and I found the trigger point, and she said, that's it. That's the pain right there. I said, so you've got what's known as a referral or a trigger point. So what we're going to do is inject this with lidocaine. So I loaded a syringe, hunted, found that trigger point. Now, if you don't inject the trigger point, you may not get the success you want. You'll always get a jump sign, a little jump, the muscle will twitch whenever you hit that trigger point. So you can just needle it and break it up, or you can inject it, but then you need to stretch that area out too that you just injected. Because injecting itself may not do anything. You've got to work that trigger point to try to break it up. The gal who wrote the myofascial book in there says it doesn't matter what you inject it with if you don't do post injection therapy on it, which is massage on it. So yes, there is therapeutic value for doing that. And we inject trigger points. I use a laser a lot now instead of injecting. People don't like sometimes us injecting in the head or in the neck or places like that. I get a little phobic about that, you know. So, but that's where I inject. I don't ever go in the mouth hardly. So I'm used to doing that. So Malin potty, again, you look at that, if you can see that, have them stick their tongue out, if you can see all the way back there, that's a class 1. We got a good view. Class 2, it's everything's kind of going out of view. You can see it, but it's not as clear. Class 3, you're hiding that uvula now and the top of the fauces in there. In class 4, they are hidden completely. Class 4, this is what gives the anesthesiologist problems getting tubes and things in. They got a big tongue. And they may not have a big tongue. They just may have a small arch and the tongue just appears big. And that happens in 4 bicuspid extraction a lot of times. And then again, we're getting a lot of growth and development issues on kids nowadays. And so there's
Another
that.
question. What type of laser do you use? Do you apply that on a daily basis for those patients?
No, I did the injection once and massaged it for her, broke it up. I told her, I said, if you have any problems, give me a call because sometimes they'll come back. She called me about, I don't know, 6, 7 months later, and I did it again. I used the laser, I did injection, I did everything on her that day. And I haven't seen her since. So either she died or moved away. I don't know, one of the two. This was years ago. So I use the MLS laser. I know there's lots of other lasers out there now, and I don't know much about the Fotona, and I know it can do a lot of things. I don't know if you can do trigger points with that, but the MLS laser is a good laser for head and neck, muscle relaxation, pain, inflammation, and things like that. I look at the septums also in this. I don't do a nose valuation. I can do that by just have them hit with their head back like this, and you can see if they've got a deviated septum in there and the turbinates are real big. Or you can just have a mirror, hold it underneath there, have them breathe out. They fog the mirror up, they've got pretty good air. Do the other side. If you don't get much fogging, they're not getting much air through there. So that's another way of telling it. I just use the X-ray now that I use.
How does the laser help with those injections? Or excuse me, with the trigger points?
It helps break up the trigger points, the heat, the penetration in the trigger points. I still take them and stretch them out once I do that. Okay. So I'm still doing the physical stuff after I use the laser on them. I've used the laser on trigeminal neuralgia. And if you find the right place where that trigger for the trigeminal neuralgia is, sometimes you can treat that with the laser. It'll go away for a few months. I had one lady, she'd come in about every 3 months, I'd have to treat her because it would come back. And again, it just disrupts or I don't really know the physiology behind what the laser does. I just know it works in there. Okay. Tongue tie, I look at tongue ties in there. Of course, the type 1s are easy to find. Type 2s and the type 4s, this is what I had. Didn't know it and got my tongue tie done about 5-6 years ago. I was hoping it would help with the fascia that goes all the way down because I have some neck issues, some organ issues in here. Being stuck didn't help me a bit. Friend of mine had his done. He's the tongue tie specialist down in Fort Worth, Stacy Cole. He went home every night with a neck ache. So he had his tongue tie done by his partner. Neck ache stopped. So it'll release the fascia a lot of times too. Infants, we need to get those tongue ties taken care of. So if you see people like this for grinding, you hopefully on the top, you're not sitting there going, oh boy, look at that. I get a bunch of crown and bridge on this guy because there's a reason he may be clenching or wearing those teeth down. And I'm sure you've probably heard it. Bruxism, bruxing because at night he's probably got a sleep problem. And at night he's moving his jaw forward like this to try to open his airway. So if you see anterior wear on the teeth like this, don't just jump in as a dentist and try to fix them. Think, why is he wearing those down and not the back teeth? It's usually the back teeth that get worn down. Here it's the front teeth. So put a little thought into what you see in there. Of course, tori is, there is some studies out there that say they can be caused by clenching or grinding in there. So that's going to tell you, number one, they can't lay their tongue down on the floor of their mouth. So the tongue's going to have to set up. They're going to have a smaller airway because the tongue's backwards a little bit. If you see that very center picture on the bottom, you see that scalloping around the tongue in there. It's a 75% predictor for sleep apnea right there. So if you're doing TMD and you look at a patient, which I had one today, saw this, and I started asking about sleep issues. So I picked up a TMD and a sleep patient from this person, or he will be because he's going to get a sleep study, and I know he's got sleep apnea. So these are just some of the things that just look for in your patients. We got the NCCL lesions up there. You know they're grinding or clenching their teeth. They're putting wear at that CE junction. Again, down on the lower left, if you didn't see the other picture, that's scalloping of the tongue. Okay, x-rays. We're getting ready to finish up here. I have a CT scan, ICAT, so it gives me a panoramic, a lateral C-spine, tomograms, and computerized tomography. So we're just trying to rule out, I go through all these pictures with my patients. I sit there, I let them see what theirs looks like. I show them pictures of good joints, opening and closing. I show them pictures of bad joints, opening and closing. By the time I get through with my interview with them, which is an hour long, they understand why they're having problem. They understand this is not going to change because it's a foundational problem. And I have anywhere from, today we had 90%, 80% acceptance of our cases. So more than that. Well, 5 out of 6 patients accepted today. The other one will. She just had to go home and talk to her husband. So the more time you spend with them and they appreciate it, they tell you they appreciate it. So you're looking at all this stuff in the panoramic. Here's other things you look for. I'm sorry. I know I'm on a time limit here. Finishing. Symmetry of mandibular body, airway, tumor, cyst, periodontal disease, periapical involvements. So this is what my ICAT x-ray looks like. If you're taking regular panoramic x-rays and you're putting that little thing that you bite on in between the teeth, that x-ray is not diagnostic for me because you've opened that spacing where the condyle is. You've brought the jaw forward, so you might as well not even send your x-ray to me. I want to see the teeth together. And this one, because the ICAT comes around even with the face, I get a better picture of the condyle, so I could actually diagnose off of this. I don't. But those are the things I'm looking for, the maxillary sinuses. I look for anagonial notching. Almost all clinchers and grinders are going to have anagonial notching in there. And then the C-spine, I'm looking to make sure we have that normal lordotic reverse C look in there, and good spacing between the occiput and C1, C1, and C2. On mine, I can only get down to about C4 at the lowest. So I'd look for those first 4 vertebrae in there. If I saw this, I would know we've got a reverse curve in it. So they've got some neck issues. That top thing at the top is called the ponticulus posticus. It's an abnormality we see in 20% of the people or so. And then here's another one, forward head posture in there. And then the sagittal tomograms, I'm just looking for everything in here. I'll point them out to you. There's my ICAT, okay? It's my workhorse in there. I've had that thing for about 15 years now. So if you look on these x-rays, get in that middle row because that's in the center of the condyle. So you're looking from left to right, you see the arthritic changes in there, how that's got beaking on it now. That second picture from the left, they've got a cyst in the middle of that condyle, and you can see it on the very top on the left up there. So the right side has arthritic changes. There's almost no space in there. So this is one that's had this problem for years. They've probably ground down their teeth a lot, decreased that spacing, or intruded them, one of the two. They may or may not have some pain in there. And here's another one. I think it's just showing the left side. I've got that thing right across that middle line. I can't see it. Here's one with a bifid condyle. If you look on the very top right, when she put the thing right in the middle, like she did, this is what she came up with. She came to me and said, "Doc, something's wrong. She doesn't have a condyle up there." So I went in there and just flipped it around. So I'm going front to back now instead of side to side. I said, "You had it right through that hole. That's a bifid. That's the bifurcation in there. If you look down on the bottom, that's what it looks like, a wishbone." So you see all kinds of weird stuff. This is an airway. So when I draw my line on the bottom picture, that gives me what the airway looks like on the top. So I can get an idea of if I can help these people as I'm talking to them. The one on the bottom looks like they don't have hardly any spacing. You look up here and it's actually got lateral spacing, and that's good, okay? Because I know bringing the jaw forward is going to bring the tongue forward, which is going to help the space. And then here's a 1.2 millimeter airway. If you look on the left picture, that's what you're seeing. And here's a 0.8 millimeter. I had one literally that was smaller than the tip of this pin. It was more like this pin right here last week, 23-year-old. And as we got started talking about his TMJ, I pointed this out. I said, "Do you have some sleep issues?" He said, "Yeah, I do." He said, "I don't sleep very well, and I fall asleep all the time. I can be driving and fall asleep. In fact, I fell asleep the other morning taking my 1-year-old to the daycare. His wife was sitting there with a 1-month-old baby in the same room. She came unglued when she heard that. She said, "You need to get this fixed." So I told him, I said, "You need to go get a sleep study because I don't know that I can move your jaw forward enough to help you. Let's see, are you mild, moderate, severe? If you're severe, you're using a CPAP. I don't care if you're 23 or what. You're not going to be around long enough to see these kids grow up if you don't." And I had that talk with them just about like that. And this one, you can see there's just no spacing on top of the condyle. Here's
Dr.
another
Bennett,
one.
we have a question.
Yes.
Does untreated sleep apnea patients tend to sleep with an abnormal head posture to open their airway? And does this cause myofascial pain in the head and neck?
It can. Most of them who don't have an airway, though, abnormal air or has an abnormal airway, I can look at the airway and I'll look at them and I'll say, "I'll bet you $1 you don't sleep on your back." And they'll go, "Yeah, how did you know?" I said, "So if you slept on your back, that small airway would be even smaller and you may die." So you've learned to sleep on your side. Now, a lot of times when people sleep on their side, their jaw kind of comes forward. Now, if they have their head back, I don't know that that's going to help any, to tell you the truth, because that jaw is going to rotate. It's going to try to come forward, but it's not going to, because gravity is still going to let that jaw drop. So most of the people who have, I'll say, severe apnea will not sleep on their backs. It could cause myofascial pain, though, because they're going to have to fix their head in a way they can breathe. It's our survival mechanism. And this is just another x-ray. One side, the right side looks good, or the side on the left looks good, side on the right is worn down. This would be somebody who had a cant possibly. And, you know, you can tell by the length of the condylar process as it comes up, it's shorter than the other side. So when you see that cant, you know, according to Dania Tamini, who's one of the radiology experts, that's the start of their TMJ problems, that cant in there. And then here's just some more stuff that I see. Another small airway. The top one's the turbinates up there. So I can run my cursor all the way from the back of the nose to the front, and I can look at the turbinates. I pick up septal deviations all the time. Septal deviations a lot of times come in growth and development. They've got a high arched palate. They don't have enough room for those nasal bones to grow together like this. So if that high arched palate takes up some of the room, then those bones come down, they meet, and then they'll go like this. So I see a lot of kids with deviated septums. Never had any injuries to their nose. Okay, this is what we do, Mayor and I. If you know Mayor Patel, we lecture for the Tufts School of Dental Medicine. And next year is, or September, starting our next 4-session mini residency. Session 1 and 3, you can stream or you can be live, either one. 2 and 4 are when we do our hands-on. We teach bite relationships. We have appliances made for you. We put those in. We go through the fitting of them, taking care of any problems. We always try to build in some problems in these things. So you'll get hands-on experience doing that. We do injections. We teach you the injections that we use. We go through a TMJ exam, just like I talked about. We'll make temporary devices, show you how to do those for sleep and TMD. Let's see, what else do we do? A lot of hands-on in those 2 sessions. So if you're really wanting to get interested in doing either one of these, because we are so hands-on and we're such nice guys, Trish will tell you that, and Frank will too, how nice we are, that we learn by asking questions and things. And neither one of us care if questions are asked during our lectures and things. That's how you learn. And we do this, both of us together. I've done this over about 35 years now. Mayor's about 20, 23 or so, something like that. So between the two of us, you have 55 years plus of practical experience to help teach you these things. So this is a great course. We've had people who are real CE junkies that say it's the best course they've ever had once they put the live stuff in there too. So you can contact Tufts. Just go to their website if you're interested in doing this. And Trish, you're up now.
Excellent. Yeah, and I can also help you with that as well. So if you need help, I know all of you at this point have my email, I'm sure. So if you need help with that Tufts course, let us know. We'll be there too. So keep us updated if we can help you get set up with that. Thank you, everyone, of course, for spending your evening with us. We're so thankful to always have you join us every single week. Like I had mentioned, the recording will be sent out to you probably early next week when it's available. So keep an eye out for that. As a thank you, we'd like to offer 20% off our milled full coverage day appliances until next Friday. So that's any full coverage days if they're ordered by the 3rd. So that can't be combined with any other discount, but if you order before then, we can give you that 20% off. The code is on the screen, so you'll want to put that on your RX. Dr. Bennett, can you go to the next slide, please?
Oh, sure. I'm sorry.
That's okay. So like I had mentioned, we do these webinars monthly. So next month, our webinar is going to be featuring the other half of BenPat, Dr. Mayur Patel, on specifically regarding managing the complications related to oral appliance therapy for OSA. So that webinar is going to be on Wednesday, April 22nd. So feel free to scan the QR code or go to our education page on our website and get registered for that. That will allow you to join us on the 22nd. And just like today, if you were to miss it, we'll send you the recording. So we hope you'll join us there. If you're new to TrueFunction and you'd like us to help you with your appliances, feel free to scan the other QR code. It'll take you right to our new account form where you can fill it out and schedule a call with me, and we can discuss your appliance needs and how we can maybe help you. Also, feel free to put in the chat any topics you'd like us to cover for our webinar series. We're always open to suggestions. We have really great partners in the industry, so we can make sure to get that education needs met for you. If you have any other questions, feel free to, I know I see a few in the chat box, feel free to keep adding those, and we'll get Dr. Bennett here to answer a few more before we finish up. Okay, Dr. Bennett. You're back on the screen here.
Okay.
What is your preferred sleep appliance?
The one that works. There are so many appliances out there, and there are so many different materials. We're in a great age right now. And I want to thank Frank and the other people that are out there working with these materials. I'm a simple person again, okay? The EMA has been around for years. It's tried, it's proven. It's a very low profile now that we can get the nylon, we can get the other materials that Frank provides for us. I like the EMA. Most people that I show I'll show 3 appliances. I don't do certain ones, just personal preferences. I'll usually show the Panthera, I'll show the dorsal, and I'll show the EMA. And most people will pick the EMA over everything. And I have great success with it. Again, now with the new materials, they're almost indestructible, almost. Frank loves hearing that. But that's the one I use the most. Frank?
Yeah, unless the pet gets to it, right, Dr. Bennett? That's
what?
Unless the pet gets to it, because that's where
yeah, exactly. Yeah, nothing's indestructible, right? But yeah, if you take care of them, those are great. They're very thin now too, low profile. You put the elastics on the buttons on the outside, which the buttons are now milled into the appliance, which is awesome. They'll never come off. And you put the elastic on there, and you don't even hardly feel anything on the outside. It's awesome.
Yeah, and TrueFunction offers all 3 of those designs. So if you have any questions on designs or anything, also feel free to reach out. We can kind of explain the different design options and material options that they go with. Next question. Can you explain again what you meant by biting down hard when you get an open bite after recapturing the disc?
Okay, so, and I had this conversation with a patient one day. She came in, her dentist had said, I don't know what Terry did to you, but he screwed up your bite. We're doing TMJ. So she comes in, sure enough, she's got an open bite. Well, we've gotten the shim back in the position. Now, you saw in those slides, whenever they showed the one with the dislocated disc, there was little spacing, but the teeth came together there, right? So something had to happen to cause that, or to allow that to happen. So when you put a 3 millimeter shim in a 1 millimeter space, Now their back teeth aren't going to come together because you can't squeeze that cartilage disc together. You can't compress it that much. So she came in and says, well, Dennis says my back teeth don't come together. I'd like for them to come together. I said, okay, we can have that happen. I said, let me ask you, all these symptoms you came in with, are you in any pain at all? No, I don't have any pain at all. Okay, so we took care of your problem by getting the disc back in position, like I told you we were going to try to do. So if we squeeze that back out of position, you may start with all your issues back again. She said, well, I don't know that I want to do that. We had this conversation for a few minutes. I don't know that I want to do that. And I said, honey, you can't have it both ways. Either the disc is in, now you've got to get some work done on the teeth, ortho or onlays or something like that, or you squeeze the disc back out of position. So taking that, I call it the watermelon seed in there thing. If I squeeze my fingers hard enough on the watermelon seed, it's going to shoot out, right? So I said, if you squeeze your back teeth together as hard as you can, or your teeth together, you can dislocate that disc because you don't have enough room for it to stay in there. So that's what I meant by that. She said, well, I don't want my disc to come back out. I don't want to be back in pain. I said, so until your dentist told you that your back teeth didn't come together, did that bother you at all? She said, no, I could eat and everything else. I said, so forget what he had to say. You're pain-free. That's what you came to me for. So that's what I meant by squeeze hard.
Perfect. Do you deal with any physical therapists that do myofascial release in combination with TMD or OSA appliance therapy?
I do. Absolutely. I've got a good group of therapists here. It's PT Solutions. I know I first saw them down in Atlanta where they lectured in our course down there. And it just so happened they were putting some places in Tulsa because one of the guy who started this is from Oklahoma. So I sat there and I talked to him, found out he's from Oklahoma. And I said, man, I wish we had some of these in Oklahoma and Tulsa. And he says, we're putting some in. So I've lectured to them too. They understand what I'm wanting when I send my patients over to them. They understand what they need to do for me. If they have any problems, they just give me a call and they'll provide some myofunctional therapy in there too.
Excellent. What's your thoughts on the TAP appliance?
You know, it's a great appliance for a lot of people. I've just never had a lot of success with it. And that includes myself. Back in the days, the old tap, Frank, you remember the big thing that came out of between the lips. This is kind of when, well, that was what, 15, 20 years ago. So something like that. Sleep was not a big thing until about 20 years ago. We were using Farah appliances for nighttime appliances for these people, TMD people, forever. And they were coming in feeling so good. And I don't know that anybody really put the aspect that we were helping their sleep, their airway, all this other stuff in there. We just thought we were protecting the joint. And so when the sleep kind of came out, I tried just about every appliance that was out at that point in time. I used every one of them for about a month to see how I felt, see how I reacted with them. The tap was the only appliance, and I set them all the same, so I didn't extend it any further out. It was the only appliance that I had TMJ problems with. And I don't have TMJ problems, but my joints would hurt and I could not get my teeth together in the morning. It took me 2 cups of coffee back then and a hot shower before my teeth could go back together. So I had that muscle change overnight, where all the others I never do. So it was kind of left a bad taste in my mouth. And so I'm not a big tap user. If somebody wants one, I can make them a tap, but I just don't get calls for them. But I know some friends of mine who use taps all the time. So I think it's what you feel comfortable working with and what you feel confident too. That's what you should use. But I'd say get 2 or 3 that that you can kind of give them a little bit of a choice. Okay.
Awesome, Trish. You're back. Thank you, Dr. Bennett.
Quite welcome. Thank you.
Trish, do we have any other questions?
Can you hear me?
Yeah,
Okay.
you're back on.
My headphones just died. So
Yeah, awesome.
we don't have any more questions. So any last minute, put it in the chat, but I think we're going to conclude here. We're so thankful for you, Dr. Bennett. So good to see you. Thank you for spending your evening with us, and hopefully we'll see you again soon.
It's enjoyable. Thank you so much for asking me.
Yeah.
You appreciate it, Doc. Thank you, Trish. Wonderful job, as always. Thank you.
Thank you.
Have a good evening, everyone. Thanks for joining us.
You're welcome. Thank you.
One more question. What material do you prefer for the EMA? And we'll wrap it up with that.
What?
What material do you prefer for the EMA?
I call it the blue material. So Frank, you tell them what material that is.
Yeah, you got me on that one. It's I'll have to bring up the name. It's a thermoplastic material. It's actually used for clear clasps. We used to injection process clasps for partial dentures out of that material. And now it comes in blue, and that's specific for the EMA. It's really great stuff. It's got a lot of flex to it. It's resilient, and as you said, Dr. Bennett, it's a one-piece deal, so there's no chance of those buttons coming off like you know, it used to be a concern.
I don't know the name of it. I got it written down on one of my scripts downstairs, and we always have
There's
to
a
look at
scientific name to it, yeah.
the blue one. Give me the blue EMA. That's all I want.
We call it the EMA milled, and so it comes in a blue color that identifies the specific product. Awesome.
Excellent.
Okay.
I think we'll call that an evening then. Thanks again, everyone, for joining us, and Dr. Bennett. Have a wonderful evening. Like I said, if you have any questions, feel free to contact me. I'm happy to answer anything regarding the lab or even getting set up with the Tufts course. So feel free to contact us, stay in touch. We love to hear from you, and feel free to share any topics you want us to cover in the future, okay?
Awesome.
Thanks,
Have a
guys.
good evening, everyone. Thank you.
Bye. Have a wonderful evening.
Bye.